Welcome back to the deep dive. Today, we're doing something a little different. This isn't just an exploration, it's really a strategy session. We are walking into the exam hall together.
Exactly.
If you're an MD anesthesiology postgraduate, maybe you're looking at the Gujarat University boards or, the national board exams, this session is for you.
That's absolutely right. We're treating this as a high-yield audio revision.
Mm-hmm.
We are taking one of the, frankly, most intimidating topics on the syllabus, cardiac arrhythmias, and we're going to dismantle it.
Dismantle it. I like that.
The goal here is to take this huge, chaotic subject and structure it into the perfect 20-mark long answer, a gold medal answer.
And we've done the heavy lifting on the sources. We've synthesized the gold standards.
Mm-hmm.
Miller, Morgan, and Mikhail for the core theory, Marino's ICU book for the critical care side, and clinical manuals like DOS for the day-to-day management.
It's all examiner-proof content.
Okay, so let's start where the examiner starts. You open the paper, you see that question, discuss cardiac arrhythmias. How do you define the beast?
You have to start with precision. Don't just write an irregular heartbeat. That's not enough.
Right.
An arrhythmia is clinically defined as any abnormality in the site of origin of the cardiac impulse, its rate, or its conduction.
Origin, rate, or conduction.
Those three pillars. A breakdown in any one of those is an arrhythmia.
It's interesting because, as anesthetists, we stare at rhythms all day long, but for the exam, and more importantly for patient safety, why do we care so much? Is it just the monitor beeping at us?
It's all about hemodynamics. It's always about the blood pressure. In the perioperative period, arrhythmias are incredibly common. Some sources suggest 60 to 80% of our patients will have some kind of rhythm disturbance.
60 to 80%, that's huge.
It is. But the why we care is strictly about cardiac output.
Mm-hmm.
When you lose a coordinated rhythm, you often lose the atrial kick.
That final squeeze from the atria.
Exactly. That final squeeze that primes the ventricle, that can account for 20 to 30% of your cardiac output. Just gone.
And in a patient with a stiff ventricle, I'm thinking aortic stenosis, chronic hypertension, losing that kick is just catastrophic.
Catastrophic is the right word. If you take away 30% of the filling in a non-compliant, stiff heart, the blood pressure just vanishes. It crashes.
And on the other side, tachycardia.
Right. If you have extreme tachycardia, you dramatically reduce the diastolic filling time. The heart is beating so fast, it literally doesn't have time to fill with blood between beats.
So either way, you're losing output.
Loss of kick or loss of filling doesn't matter. The end result is hypotension, which can spiral into cardiac arrest very, very quickly in an anesthetized patient.
So for the exam paper, we're thinking about this in a few different ways. You've got the long answer, something like classify arrhythmias and discuss management of perioperative SVT.
A classic.
Then you have the short notes, which love to pick on specific things like the reentry mechanism or a specific drug, maybe magnesium in arrhythmias.
Or Mobitz type 2, they love that one.
And then, of course, the Viva or the OSCE, where they just hand you a rhythm strip and watch you sweat.
And our entire job today is to make sure that you don't sweat.
Okay, let's build that foundation. Basic electrophysiology. I know residents often want to skip this section to get straight to the drugs and the ACLS algorithms, but you argue this is actually where the marks are hidden, right? It's extremely high yield. In fact, I'd say it's essential. If you can explain the mechanism of an arrhythmia, you automatically understand the pharmacology. The why behind the drug choice becomes obvious.
So where do we start?
You need a very brief recap of the conduction system. You can even draw it. SA node, the internodal tracts, the AV node, which you should call the gatekeeper, then the bundle of His, and the Purkinje fibers.
The electrical superhighway of the heart.
Right. But the real core of your answer, the part that gets you the top marks, needs to be the big three mechanisms of arrhythmia. Examiners love this section.
The big three. Okay, let's unpack them. Mechanism number one is abnormal automaticity. Right, so normally only the SA node is the pacemaker. It's the fastest. So it suppresses all the other potential pacemakers in the heart. It has overdrive suppression.
It's the boss.
It's the boss. But in abnormal automaticity, other cells that shouldn't pace, we call them latent pacemakers, they start firing off on their own. Or the SA node itself just goes rogue and speeds up inappropriately.
And physiologically, what's happening at the cell membrane level?
If you think back to that action potential curve, it's all about phase 4. There's an increase in the slope of phase 4 spontaneous depolarization.
So the cell membrane is just drifting up to its firing threshold much faster than it should. What causes that in the OR?
Sympathetic stimulation is the big one. Pain, light anesthesia, anxiety, catecholamine infusions.
So a surgical incision without enough analgesia.
Classic trigger. But also chemical factors. Hypokalemia is a huge one. It makes the membrane potential more unstable, closer to threshold, and then there's mechanical stretch.
Heart failure.
Exactly. If a heart is failing and dilated, the physical stretch of the myocardial cells makes them electrically irritable, and they can start to fire on their own.
Okay, that makes sense. So mechanism number 2, triggered activity. This one always feels a bit more abstract to me.
Think of it as an electrical glitch or an aftershock. These are called afterdepolarizations. Essentially, the cell fires a normal beat, but while it's trying to reset, the membrane potential oscillates. It wobbles. If that wobble is big enough, you can reach threshold and trigger a whole new unwanted beat.
And we split these into 2 types, right? EADs and DADs.
Exactly. Early afterdepolarizations, or EADs, happen during phase 2 or phase 3 of the action potential, so the cell hasn't even fully repolarized yet.
It's being triggered before the last beat is even over.
Precisely. This is the key mechanism behind long QT syndromes and the arrhythmia everyone's heard of, torsades de pointe. The action potential is so prolonged that some of the ion channels start to recover and misfire before the cycle is complete.
And dead EADs, the delayed ones.
Delayed afterdepolarizations occur after repolarization is totally complete, back in phase 4. The classic exam association here is digoxin toxicity, or any state of intracellular calcium overload.
Why calcium?
Because the cell is just stuffed with calcium, which causes it to be unstable and to twitch electrically even after it should be resting quietly. It's a calcium-driven phenomenon.
Got it. EADs linked to long QT, DIDs linked to digoxin and calcium. Now, for mechanism number 3, the one you're called the exam favorite, reentry.
This is the one. It is the most clinically significant mechanism. This explains atrial flutter, it explains most PSVTs, and crucially, it explains most ventricular tachycardias in hearts with scar tissue.
So it's a circuit problem.
It's purely a circuit problem. The traffic circle analogy is really the best way to visualize this.
So let's use it. How does the traffic circle work?
Okay, imagine an electrical signal traveling down a road that forks into 2 lanes, lane A and lane B. Normally, the signal goes down both lanes at the same time and everything is fine. But for re-entry to happen, you need 3 specific conditions.
3 conditions.
First, the 2 lanes must have different electrical properties. Usually one is a fast lane with a long recovery time, a long refractory period. The other is a slow lane with a short recovery time.
Okay, different speeds, different recovery times. What's the second condition?
You need a unidirectional block.
Like a one-way straight or a do not enter sign?
Exactly. A premature beat comes along, an early beat.
Yeah.
It tries to go down the fast lane, but the fast lane is still recovering from the last normal beat. It's refractory, it's blocked.
So the door is closed on the fast path.
The door is closed, so the signal is forced to take the only available path, which is the slow lane. It trundles down the slow lane.
And by the time it gets to the other end of the fork?
By the time it reaches the bottom, the fast lane has finally had enough time to recover. It's open for business again. So the signal doesn't just go forward to the ventricle. It sees this open road, and it turns around and travels backward retrograde up the now recovered fast lane.
It does a U-turn.
It does a U-turn, and if the timing is perfect, when it gets back to the top of the fork, the slow lane is ready to go again.
And you're stuck in a loop. Like a car in a roundabout, just spinning in circles.
Precisely. It's a circus movement. And every time that signal completes a loop, it sends a wave of depolarization out to the heart, causing a beat. That's your tachycardia.
And our antiarrhythmic drugs are designed to break that loop.
That's all they do. They either slow conduction even more in one of the pathways, or they prolong the refractory period, trying to make one of the lanes not ready when the signal comes back around. You're trying to break the synchronization of that circuit.
That's a fantastic explanation. Okay, so we've covered mechanisms. Let's move to the next major section of our long answer. Classification of cardiac arrhythmias. How do we structure this on the exam paper to get the marks?
The most important thing is, do not just list rhythms randomly. Examiners hate laundry lists. They want to see that you can think systematically. They love taxonomy.
So start broad.
Start with the simplest primary classification, which is based on heart rate. It's either a bradyarrhythmia, less than 60 beats per minute, or a tachyarrhythmia, greater than 100.
Simple enough. But the secondary classification is where the real clinical decision-making comes in, isn't it?
Yes. This is the classification based on origin. And visually, you determine this by the QRS width. This is the absolute core of your answer.
Narrow versus wide.
If the QRS complex is narrow, that's less than 120 milliseconds, or 3 small squares on the ECG, the origin is supraventricular. It's coming from somewhere above the bifurcation of the bundle of His.
Why does that make it narrow?
Because the signal, once it gets through the AV node, is using the heart's normal high-speed conduction system, the Purkinje fibers. The depolarization spreads through the ventricles very quickly and efficiently, creating a narrow, sharp spike.
And if it's wide?
If it's wide so, greater than 120 milliseconds, it implies the signal is not using that superhighway. It's traveling slowly from muscle cell to muscle cell.
Which means
It usually means it is ventricular in origin. It started in the ventricle and is spreading outwards. Or, and here's the exam trap, it's a supraventricular rhythm with aberrant conduction, like a bundle branch block.
But you have a golden rule for this.
I do. And you must write this down. Clinically, and for any exam, a wide, complex tachycardia is ventricular tachycardia until proven innocent. You must treat it as the more dangerous rhythm.
Guilty until proven innocent. We'll definitely come back to that. Okay, let's drill down into the specific rhythms, starting with the slow ones, the bradyarrhythmias.
Right. And in anesthesia, sinus bradycardia is incredibly common. We cause it all the time.
High spinals.
High spinal anesthesia, blocking the cardioaccelerator fibers, high-dose opioids, dexmedetomidine, neostigmine for reversal. These are all powerfully bradycardic.
So what's the treatment philosophy?
Only treat if it's symptomatic. If the heart rate is 45, but the mean arterial pressure is 80, and the patient is perfusing well, you just watch it. If the pressure starts to drop, then you escalate, starting with atropine or glycopyrrolate to block the vagus nerve. If that doesn't work, something with sympathomimetic action like ephedrine.
Okay, now the AV blocks. This is pure Viva Gold. Walk us through the degrees.
First-degree AV block is the simplest. The PR interval is prolonged, so it's greater than 0.20 seconds or one large square. But every P wave does get through to the ventricle. It just takes a little longer.
So it's just a delay.
It's a delay. It's usually benign. You see it in athletes with high vagal tone. We just watch and wait.
Then we get to second degree. This is where it gets trickier, and the names can confuse people.
Second degree is the key differentiator. You have Mobitz type I, which is also known as Wenckebach. The hallmark here is group beating. You see the PR interval get progressively longer and longer, longer and longer until pop, the QRS is dropped. The whole cycle restarts.
The classic going, going, gone.
That's the one. The pathology here is usually in the AV node itself, and it's generally benign. But then you have Mobitz type 2.
The dangerous one.
Very dangerous. In Mobitz 2, the PR interval is fixed. It doesn't lengthen. It's normal, normal, normal. And then suddenly, without warning, you drop a QRS.
And why is that so much more serious?
Because it implies the disease is in his Purkinje system, so it's below the AV node. The structural integrity of the conduction system itself is failing. This has a very high risk of suddenly progressing to a complete heart block.
And there's a specific exam trap regarding the treatment, isn't there?
Yes. Atropine works by blocking vagal tone at the AV node. In Mobitz 2, the problem is below the node, so atropine often fails or can even make things worse. These patients need pacing. You cannot just drug your way out of his Purkinje block reliably.
Which leads us perfectly to third degree, or complete heart block.
This is complete AV dissociation. The atria are doing their own thing, beating at their own rate, and the ventricles are beating at their own, usually much slower, escape rate.
And on the ECG?
The P waves and the QRS complexes are completely independent. The P waves just march right through the QRS complexes with no relationship whatsoever.
There's a specific physical sign in the neck veins they love to ask about here.
Canon A waves. It's a great Viva question. Since the atrium and ventricle are disconnected, sometimes the atrium contracts while the tricuspid valve is slammed shut because the ventricle is also contracting.
So the blood has nowhere to go.
Nowhere forward. So it shoots backward up the jugular vein. You see this massive pulse in the neck. The management is mandatory pacing. There's no other option.
And final point on that, if the QRS is wide in a complete block, what does that tell you?
It tells you the escape rhythm is coming from the ventricles themselves. And that is a slow, unstable, and very unreliable pacemaker. That patient is in serious trouble.
Right. Let's shift gears to the fast stuff. The supraventricular tachyarrhythmias, or SVTs. These are incredibly high yield because we see them all the time.
All the time.
Yep.
And you should start with the most common one, sinus tachycardia. The most important thing to tell the examiner is that sinus tachy is a symptom, not a primary disease.
It's a physiological response.
Exactly. It's a response to something. Pain, light anesthesia, hypovolemia, fever, sepsis. Your job is to treat the underlying cause. Don't just throw beta blockers at it blindly, or you might be masking a sign of impending shock.
Good point. Next up, atrial fibrillation, the classic irregular rhythm.
No P waves, just chaotic fibrillation waves or
Yeah.
puff waves. The baseline is a mess, and the RR interval is all over the place. The big anesthetic risk here, as we said, is the loss of the atrial kick.
And in the wrong patient.
In a patient with aortic stenosis or diastolic dysfunction who really depends on that kick to fill their ventricle, the new onset of AF can absolutely crash their blood pressure.
And the management is that classic debate, isn't it?
It is. Rate control versus rhythm control. In the acute setting, if the patient is hemodynamically stable, we often opt for rate control. We use drugs to slow the ventricular response.
Like beta blockers or calcium channel blockers.
Desmolol, metoprolol, diltiazem are the classics. But if they're unstable, if they're hypotensive, we have to move immediately to rhythm control with synchronized cardioversion.
What about the clot risk with AFib? That's a huge consideration.
A crucial nuance for the exam. If AF has been present for more than 48 hours, there's a significant risk that a thrombus is formed in the left atrial appendage. If you then cardiovert them back to sinus rhythm, the atrium starts contracting properly again and can kick that clot straight into the brain, causing a massive stroke.
So what's the rule?
If it's been more than 48 hours and they are stable, you must anticoagulate them for a few weeks before attempting cardioversion. If they are actively dying of hypotension, you have to shock them anyway and accept the risk because life comes before limb, or in this case, brain. But you must mention that risk.
Good. Okay, what about atrial flutter?
For flutter, you need to look for the classic sawtooth pattern on the ECG. Those are the F waves. It's a macro reentry circuit, usually in the right atrium.
And the rate is often a giveaway.
The atrial rate is usually fixed at around 300 beats per minute. Because the AV node is a good gatekeeper, it usually blocks every other beat to protect the ventricle. So you often see a ventricular rate of exactly 150.
A 2-to-1 block.
Exactly. If you see a rock-steady, narrow, complex tachycardia at 150, you must think of atrial flutter.
And finally, for SVTs, PSVT, paroxysmal supraventricular tachycardia.
This is usually due to that AV nodal reentry circuit, the AVNRT we talked about earlier. It's characterized by its sudden onset and offset.
And the treatment ladder?
You start with simple things. Vagal maneuvers, get the patient to bear down like they're having a bowel movement, the Valsalva maneuver. Or you can do carotid sinus massage, but be careful in older patients with plaques.
And if that fails?
Then you move to adenosine. It's essentially a chemical cardioversion.
Can you explain how adenosine actually works on that reentry circuit?
Yes. Adenosine is a very, very short-acting drug that causes a transient complete conduction block in the AV node. It lasts for just a few seconds. It effectively slams on the brakes inside that reentry loop.
It breaks the circuit.
The signal hits the block, the loop dies, the circus movement stops, and it gives the sinus node a chance to take over again and restore normal rhythm.
Yeah.
It's a chemical reset button.
A reset button. I like that. Okay, now we enter the danger zone. Ventricular arrhythmias. This is an exam favorite because this is what kills people.
It is. And we start with the precursor, the VTC ventricular premature complexes. You'll see a wide, bizarre-looking QRS with no preceding P wave, and it's usually followed by what we call a compensatory pause.
Are they always dangerous?
1 or 2 are fine. Most healthy people have them. But you start to worry if you see more than 6 per minute, or they're multifocal, meaning they have different shapes, suggesting they're coming from different irritable spots in the ventricle.
And there's one specific pattern that's really ominous.
The R on T phenomenon. This is where the VPC lands directly on the T wave of the preceding beat.
Why is that so bad?
The T wave represents the relative refractory period. The heart is in the middle of repolarizing. It's electrically vulnerable. If you deliver an electrical stimulus like a VPC, during that precise window, you can throw the ventricles into complete electrical chaos.
You can induce VF.
You can induce ventricular fibrillation. R on T is a medical emergency.
Let's talk about VT, ventricular tachycardia.
Defined as 3 or more VPCs in a row at a rate greater than 100 beats per minute. You could have monomorphic VT, where every beat looks the same. This is usually related to a stable electrical circuit around an alt scar, maybe from a past heart attack.
And the other type
is polymorphic VT, where the QRS shape changes from beat to beat. Looks like a ribbon twisting and turning.
And the specific type of polymorphic VT that always comes up in exams.
Torsades de pointe. It's French for twisting of the points. And it looks just like that on the ECG, a streamer twisting around the isoelectric line. The QRS complexes get bigger, then smaller, then bigger again.
And it has a very specific cause.
It is almost always associated with a prolonged QT interval.
We'll get to the treatment in a moment, but I want you to reemphasize that golden rule you mentioned earlier about wide complex tachycardia.
I will say it again, because it could save a life, and it will definitely save you in a Viva.
Hmm.
If you see a wide complex tachycardia, you must assume it is VT until proven otherwise.
Don't get fancy.
Do not try to be clever and call it SVT with aberrancy. The reason is simple. If you treat VT with the wrong drugs, like verapamil, a calcium channel blocker, thinking it's SVT,
Yeah.
you can cause profound vasodilation and cardiac collapse. You can kill the patient.
But the other way around is safer.
If you treat SVT with amiodarone, thinking it's VT, the patient will almost always be fine. So safety first, wide is bad. Treat for VT.
And finally, the worst of them all, ventricular fibrillation, or VF.
This is chaotic, shapeless electrical activity. The heart is just quivering like a bag of worms. There is no mechanical pumping. There is no pulse. There is no cardiac output. This is cardiac arrest.
And the treatment
Is immediate defibrillation. There is no other treatment. Drugs don't work to convert this rhythm. CPR keeps the brain and heart alive with some blood flow, but only a high-energy electrical shock can reset the heart and fix the problem.
We've covered the what. Now let's talk about the why. What causes all this in our world? Perioperative and ICU pauses. We use the mnemonic H's and T's, but maybe an anesthesia-specific version?
Absolutely. Hypoxia is the #1 suspect in the operating room. If a child suddenly develops bradycardia during a case, your first thought is hypoxia. Always check the tube, the circuit, the oxygen supply.
What's next?
Hypercarbia. A high CO2 level causes acidosis and a massive release of catecholamines, which makes the heart incredibly irritable.
And electrolytes. They're a huge player here.
Huge. Hypokalemia promotes automaticity and is a very common cause of ventricular ectopi. Hyperkalemia is the silent assassin. It gives you those tall peak T waves, then the QRS widens, then you get a sine wave, and then a systole.
And the forgotten electrolyte.
Magnesium. Do not forget hypomagnesemia. This is the classic culprit behind torsades de pointe and also refractory VF. If you're shocking a patient in VF and it's not working and the potassium is normal, you must give magnesium.
And since this is an anesthesia exam, we have to mention our own drugs.
Of course. The volatile agents, historically halothane was the worst, but even modern agents like sevoflurane sensitize the myocardium to catecholamines. Cetynolcholine can cause massive hyperkalemia in patients with burns or denervation injuries. And of course, local anesthetic systemic toxicity, or LALAST, is a classic cause of intractable arrhythmia and cardiac arrest after a regional block.
There's one mechanical cause I see all the time in the ICU. It's so simple but often missed.
I know the one you mean, the central line guide wire.
That's it.
If you insert a central line and you push the guide wire in too deep, you start to tickle the endocardium of the right ventricle. You'll see these runs of VT on the monitor. The treatment isn't amiodarone. The treatment is pull the wire back a few centimeters.
Okay, fantastic. Let's move to the how. Management principles. The examiner asks you, how do you manage a patient with a new intraoperative arrhythmia? How do you begin to write that answer?
You must start with an algorithm. Do not just start listing drugs. That shows poor clinical reasoning. Step 1 is always assess stability.
Is the patient hemodynamically stable?
Exactly. Look at the blood pressure. Are there signs of shock, poor perfusion, altered mental status if they're awake? Stability dictates everything that follows.
So step 1, assess stability. Step 2.
Treat reversible causes. This is so important. Fix the potassium, give more oxygen, deepen the anesthesia if they're light and in pain, and pull back that CVP wire. You might fix the problem without a single antiarrhythmic.
And step 3.
Then you decide on the overall strategy. Rate versus rhythm control. In an acute, unstable situation, it's always rhythm control. You need to get them back to normal sinus rhythm right now.
So stability really dictates the urgency of your actions.
It dictates everything. If they are unstable, hypotensive, crashing, you do not have time for IV infusions to take effect. You have to move directly to electricity.
Okay, let's detail that emergency management. Unstable tachyarrhythmias. What's the protocol?
Synchronized cardioversion. The key word is synchronized. You must press the sync button on the defibrillator.
And why is that so critical?
The machine then looks for the R wave of the QRS complex and delivers the shock precisely on it. This ensures the shock is delivered during depolarization, avoiding that vulnerable T wave period we talked about. If you deliver a shock on the T wave, you can induce VF.
The R on T phenomenon, but this time we caused it.
Exactly. The dose is typically biphasic, 100 to 200 joules.
But there's one rhythm you never, ever sync.
Ventricular fibrillation. You cannot sync to VF because there is no R wave. It's just chaotic electrical noise. For VF, you use unsynchronized defibrillation. Just charge and shock.
And for pulseless VT?
Treat it exactly like VF. If there's no pulse, there's no cardiac output. Don't waste time trying to sync. Defibrillate immediately.
What if it's a stable, wide, complex tachycardia? The patient is talking to you, the blood pressure is okay.
Then we have time for drugs. The drug of choice, according to most algorithms, is Amiodarone, a loading dose of 150 milligrams IV over 10 minutes, followed by an infusion.
Alternatives?
Lidocaine is a good alternative, especially if you suspect the VT is caused by myocardial ischemia.
And for symptomatic bradycardia, that's causing hypotension.
First-line drug is atropine, 0.5 milligrams IV. If that fails, we move to infusions of chronotropic agents like epinephrine or dopamine to drive the heart rate up.
And if drugs fail completely?
Then you need to pace them. In an emergency, we use transcutaneous pacing. You put those big, sticky pads on the patient's chest. It's painful if they're awake, but it's life-saving. That then acts as a bridge until you can get a proper transvenous pacing wire inserted.
Anesthetic considerations are crucial for this long answer. How do we prevent these arrhythmias from happening in the first place?
It starts with good pre-op optimization. Make sure the electrolytes are normal, especially potassium. It should really be above 4.0. And continue their existing antiarrhythmic medication.
Especially beta blockers.
Absolutely. If a patient is on a beta blocker, do not stop it before surgery. Abruptly stopping it can cause a rebound tachycardia and hypertension, which can precipitate ischemia.
And during induction, that's a high-risk time.
It is. We want to blunt the intense sympathetic surge of laryngoscopy. We can do that by giving IV lidocaine, about 1.5 milligrams per kilogram, a minute or two before we instrument the airway, or a good, solid dose of an opioid like fentanyl.
And during maintenance of anesthesia?
Just good, basic anesthetic care. Avoid hypoxia and hypercarbia. Ensure the depth of anesthesia is adequate. A patient who is too light is in pain, and that will cause tachycardia.
There's a specific point in our sources about regional anesthesia and bradycardia.
Yes, the high spinal and the basal-gyrus reflex. This is a classic. If you place a spinal anesthetic that goes too high, up to the T1, T4 level, you block the sympathetic cardioaccelerator fibers to the heart.
So you've taken away the gas pedal.
You've taken away the gas pedal. At the same time, the spinal causes massive vasodilation, so blood pools in the legs and venous return to the heart plummets. The heart is now empty, but it's trying to contract hard.
What does that do?
Mechanoreceptors in the ventricular wall sense this empty squeeze, and they paradoxically trigger a massive vagal parasympathetic response. The idea is to slow the heart down to allow more time for it to fill.
So you get a double whammy, hypotension from the vasodilation and severe bradycardia from the reflex?
Yes, and it can rapidly progress to a systole. You had to treat it aggressively with fluids to fill the tank, and a vasopressor that also increases heart rate, like ephedrine or even small doses of epinephrine.
We're nearing the end, so let's talk about the things that really separate the good answers from the great ones. Common exam questions and Viva traps. We've already hammered the SVT with Aberrancy trap.
We have, but let's say the examiner pushes you. They say, okay, doctor, I accept your principle of treating as VT. But for academic purposes, how would you differentiate VT from SVT with aberrancy on an ECG if you had time?
What do you say?
The first thing you look for is AV dissociation. If you can find P waves that are marching along at their own rate, completely independent of the wide QRS complexes, that is highly specific for VT. You look for fusion beats or capture beats. A fusion beat is when a normal sinus beat and a ventricular beat happen at the exact same time, and their waveforms merge to create a hybrid-looking complex. A capture beat is when one of those sinus beats sneaks through the AV node at just the right time and produces a single, normal, narrow complex in the middle of all the wide beats.
And if you see either of those?
They are pathognomonic. It is 100% ventricular tachycardia. The discussion is over.
Another specific question they love, what is the treatment for torsades de pointe?
They will ask this. You say magnesium sulfate, 2 grams CV. Even if the serum magnesium level is normal, it works at a cellular level to stabilize the membrane.
And what's the other part of the treatment, the physiological trick?
Overdrive pacing. You deliberately speed up the heart rate with a pacemaker. A faster heart rate naturally shortens the QT interval, which removes the substrate for the arrhythmia to recur.
Let's visualize the exam paper. You have 20 minutes, maybe 25, to write this whole answer. You need to use your time efficiently. What diagrams are you drawing?
Diagrams save time and score a ton of marks. You should draw at least 3.
Diagram 1.
The cardiac action potential. Draw the curve. Label the phases 0 to 4. Label the axis voltage versus time. And crucially, show where the main ions move. Sodium in at phase 0, calcium in at phase 2, potassium out at phase 3. It shows you understand the basic science.
Diagram 2.
The re-entry circuit. Just draw a simple diamond shape. Label one side as the fast pathway and the other as the slow pathway. Draw a little block line on the fast pathway and then an arrow showing the signal circling the loop. It explains the entire mechanism in one picture.
And the third one.
The management algorithm. A flowchart. At the top, tachycardia. Then branch to narrow versus wide. Then regular versus irregular. And then list the key rhythms and first-line treatments in each box. Examiners love flowcharts.
What about sketching ECGs?
If you're confident, yes. If you can draw a clear sawtooth pattern for atrial flutter or the Vankabach steps of long, longer drop, do it. It shows you really know the morphology.
Excellent advice. Let's bring it all home. Let's summarize and wrap this up.
Okay, to recap for the exam, the structure of your perfect answer is
Define it. Origin, rate, conduction.
classify it. Start with Brady versus Tachy, then narrow versus wide QRS.
Explain the mechanism. Mention all three, but spend the most time on reentry.
Manage it. The algorithm is key. Is the patient stable or unstable? Unstable gets shock. Stable gets drugs.
Always bring it back to our specialty. Mention the perioperative causes, hypoxia, electrolytes, anesthetic drugs, the CVP wire.
That's a great framework. And for a final thought, something for the listener to take away and mull over.
I'd leave you with the concept of pro-arrhythmia. It's one of the great ironies of cardiology. Almost every single antiarrhythmic drug we use has the potential to cause new and sometimes worse arrhythmias.
The cure can be the cause.
It can. Amiodarone, our go-to drug for VT, famously prolongs the QT interval and can cause torsades. Flecainide can slow conduction so much it creates a new reentry circuit. We are manipulating the fundamental physics of the cell membrane, so we have to treat these rhythms, but we must respect the drugs.
The final lesson is to treat the patient, not just the monitor.
That's it exactly.
That's it for this deep dive. Good luck with the exam. Go and write that 20 marker.
You've got this.
See you next time.